basically I'm going to share with you our experience on tele-ophthalmology. Just to show you, you know that in the histories, Sanjayan was given the so-called divine eyes so that he could describe to Dhritarashtra what was happening in the Mahabharata war. Today, I think IT has given us that divine vision for us to treat patients at a remote distance. All of you are aware of Mr. Prahlad. C.K. Prahlad was a management guru who had shown that more than 4 million people are living at the base of the pyramid, almost that what he calls as below the poverty line, where their income is less than $5. And what are the challenges, especially for these people who are at the base of the pyramid? The market conditions, if you look at it, this is a large unserved population, there's a resource scarcity, increasing lifestyle diseases such as diabetes, low affordability, and poor logistics. What is needed today is definitely a scalable model. You have to utilize maximally the resources that are available. Remote diagnosis and delivery is the key thing that we have to focus on, and of course dramatic reductions in the cost so that it becomes accessible for the people at the base of the pyramid. In eye care, today there are worldwide about 37 million people who are blind. There are more people who are blind in country like India with a population of more than 1.1 billion. And if you look at India alone, there are more than 200 million people who need eye care in some form of either glasses or otherwise, and who are not aware or who have not accessed it. So IT definitely offers a viable solution. IT can be utilized at 3 levels of primary eye care, at the primary, secondary, and the tertiary care. Primary, more for screening and preliminary treatment, secondary level for basic teleconsultations, and tertiary level to reach advanced specialty hospitals. I'm going to share with you just 2 case studies on using IT to provide primary eye care and then provide advanced diagnostics. Aravind Ophthalmology Network was founded in 2002, and we have various activities. I'm just going to focus on 2 things, that is the Vision Center and the mobile van. What are these Vision Centers? These are permanent low-cost eye care facility to reach the unreached and to serve the base of the pyramid and facilitate optimal utilization of whatever facilities that are available today. These Vision Centers are set up for every 50,000 population. It's not manned by a doctor, it's manned by a trained technician who is capable of doing basic eye examination, dispensing glasses, doing first aid treatments, and the important thing is they have the connectivity to the base hospital. So when a patient walks in, they are examined by these technicians, and then once they do that completed, they consult with the physician at the base hospital, and if necessary, they would refer them to the tertiary hospital or the base hospital. Today we have Aravind Eye Hospital is located 5 vision centers in the state of Tamil Nadu, closer to Madurai, in a district called Theni. What is the technology used in connecting these things is the simple Wi-Fi 802.11b. We use a unidirectional antenna. The important thing here is to have a line of sight. And today it's up to 50 kilometers we can reach, but I believe today it's possible to scale up to 100 kilometers using this Wi-Fi. Why Wi-Fi? It's free, not in any bandwidth, no licensing required at this point of time. And the cost per node of just setting up these antennas could be around 1 lakh. But the recurring cost here is negligible. We have been working with the University of Berkeley, especially with the Professor Eric Brewer from University of Berkeley in this technology. It's just to give you how these vision centers work. When a patient walks in, is examined by the technician. They do all the preliminary examinations that they need to do. Even for the eye, we have developed a low-cost way of capturing the retinal images, which normally would need a high-end cameras, and these are uploaded to the hospital. And then after that, they have a video conferencing with the doctor so that the patient is assured. So every patient who walks in is getting a consultation today. We have done about 20,000 consultations since it started. The last Vision Center was started just in June 2006. It has become financially viable how we charge a consulting fee of rupees 10. Why rupees 10? Like if a patient has to go to the nearby town, he's going to spend more money in terms of the fees, bus fare, and also the consulting fees at the hospital. And of course, he's not going to go alone. He has to take an attender. And if you look at the cost, it just builds up. So people have been able to access this particular mode of treatment. And there's a high utilization, almost 775 consults per day. By using the paramedics, the cost is definitely low. It's been a sustainable model, and it definitely can become a scalable model. The other case study I was going to talk about is the mobile van. Today, as Dr. Ganapathy pointed out, diabetes is a major problem. India is already the diabetic capital of the world. I don't know, we should not be proud of that, but it's sad that we have to take steps to prevent complications related to due to diabetes, and in the eye, what we call it as diabetic retinopathy. The problem here is it's an early on, this disease is symptomless, wherein the patient can be treated and those patients do not come to you. So you have to go screen these patients and make sure that they are caught early so that blindness can be prevented. Today in a non-hospital setting, we can either the doctor can go physically to these remote areas and screen the patients, or a paramedic can be sent. We use the paramedic in a mobile screening van with the satellite connectivity supported by ISRO, where the mobile van has a facility to capture the fundus images. A technician does that. We used a special software to send these images to the base hospital, what we call as reading center. At the reading center, the images are seen by an ophthalmology, a retinal specialist, looks at all the images, grades them, and sends a report. And within 1 hour, the patient gets a report in his hand saying that what is the status of eye, and he's counseled by the local person there, a counselor in the mobile van, on what the next step of action should be. So what was interesting to note in this is almost 70% of the patients who were diagnosed to have some form of diabetic retinopathy had never had their eyes examined. So why? Because they all had good vision, and so unfortunately these people would have been waiting till their vision was affected. And this is just to show you how almost 77% of the patients were diagnosed for the first time using this mobile van. Why Aravind Eye Care System went to do this? This is just Aravind was noted as one of the highly wired organizations by Business Today in the top 20. And because these are, Aravind Eye Hospital is located in 5 different cities and connected with, all these hospitals are connected. Today, we see about 6,000 outpatients in hospitals, 850 surgeries. These are per day volume, and examining 1,500 patients in a screening camp, and of course, a lot of teaching. This makes Aravind the largest provider of eye care services and trainer in the whole world. But unfortunately, we still see this situation wherein you see this girl with, of course, this is an African girl, with bilaterally mature cataract, wherein she can't see. But if you see where doctors have not reached her, a global person like Coke or Pepsi has reached her. You can see by the earring that she's wearing a Coke can. So to summarize, telemedicine could be a viable alternative in places with resource constraints. The bandwidth constraints are something we have to deal with, and in future, the way it is developing, I'm sure it will increase to bridge the digital divide and to bring this universal benefit of these technologies to the rural people where the whole population is, and if utilized effectively, could prevent a lot of economic burden due to the poor healthcare. Thank you.